Hello everyone, welcome to my presentation. My name is Sophie Perrik. I'm from Zurich, Switzerland, and I'm going to talk a bit about other sites than breast and DIPH treatment for which SGRT can be useful. Before I start with my presentation, I'd like to thank the SGRT community for this opportunity, and I wish everyone a very nice and fruitful Congress 2020. I'd like to tell something about the different sites that we have and are using SGRT for in our clinic. I start with a small timeline just to let you know how long we've already been using SGRT and for what sites we use it. The two specific cases I will go into a little bit deeper are the leg and a knee. I have a head and neck thing, and there are some future ideas and challenges. Again, I'm calling in from Zurich in Switzerland. I'm working as the chief radiation therapist at the University Hospital in Zurich, right in the middle of Europe. And on the left side, just a little pretty view that we have from the top of our hospital. So our clinic momentarily has 3 variant TrueBeams on campus. We have a satellite center with another variant TrueBeam on LINAC. We have a Meridian brachytherapy, brachytherapy, orthovoltage, intraoperative radiotherapy, 4 wards, 2 specifically dedicated for radiotherapy and 2 palliative care wards. The team of radiation therapists that I work with exists of 21 radiation therapists from about 12 nationalities. We have 6 dosimetrists, 9 medical physicists, and 10 radiation oncologists. From the 4 LINACs that we have combined from campus and the satellite center, 3 of them are equipped with SGRT devices, in our case VisionRT, or AlignRT devices. The first system was already installed in July 2014, and we've been using it ever since. In May 2016, we received a second system. This was first installed on a Trilogy. After the Trilogy was transformed into a TrueBeam, the system was moved to TrueBeam. And in October 2020, recently, when our satellite center opened, we got our third SGRT system that's also installed on a TrueBeam variant LINAC. We are using the 4 last version of VisionRT, and we will get an upgrade to the newest version either this year or in the first quarter of 2021. This still has to be decided. Our clinical standards at the moment are breast, both right and left, as in free breathing and DIBH. For our breast boost, we often use a photon boost, a partial breast boost technique with table rotations, and in this case we also use VisionRT to maintain position and monitoring the patient movement during the table rotation movements. We have since about 1 year, all our thorax and abdomen patients that are treated on the 3 TrueBeam LINACs with SGRT devices are used for monitoring. We use SGRT as a setup method for the thorax and abdomen patients on these machines, and that has converted into a tattoo-less workflow. The patients already know on CT to which machine they go, which means we can easily select the patients that we use for the tattoo-less workflow. And when they then arrive on the first treatment or the second treatment, we use landmarks such as the Xiphoid to maintain a standard from which the shifts are calculated, and use that as a rope way to go into the right direction. For the final positioning and setup, we use SGRT and Vision RT. We use these methods, tattoo-less, for both SBRT and conventional treatments in the thorax and abdomen region. If and when we can, we'd also like to use SGRT for sarcoma patients or the positioning of extremities. I'll be going into that a little bit deeper on one of the next slides. This is a timeline. As I said before, in July 14, we got the first SGRT device on a Varian TrueBeam. We started using SGRT for setup from breast patients, first in free breathing. After we looked into our workflow, did some research, we started with a DABH workflow. And in the last year and a half, we started to reduce imaging. We used to do daily MV imaging for our free breathing and DABH patients. Now that we've trained our staff well, we've got mandatory training from the company that supplies our SGRT. We are in a routine with the physics and the doctors to redo and look over our standard of practice. So we've started using less imaging because we trust our SGRT devices fully. That means once a week we still do imaging, and we have a protocol for when and if the imaging and the setup from the SGRT does not comply with each other. In 2017, we had an interesting case of a patient who had so much severe claustrophobia that she couldn't tolerate a mask, even after 3 different times trying to make one at CT. We ended up treating her completely without mask and with the support of SGRT. I tell you a little bit about that later on. Midway through 2018, when we got our second SGRT device switched to the Varian TrueBeam, we started using it for extremities. The reason behind this is that we have one TrueBeam for which we can extend the collimator and the field length up to 40 centimeters, which is where our sarcoma and extremity patients are usually treated on this machine. Since we have the SGRT capability on this machine, we started using it for extremities. In the last one, in the end of 2019, we started a clinical trial for the comparison between closed-faced and open-faced masks for brain tumor patients. It's an ongoing trial, but for the open-faced mask, we use the SGRT to support. Okay, let me go into deeper to the 2 examples that I wanted to talk about. One is an upper right leg. As you can see here, this is the position that we positioned the patient in. It's a secondary tumor of the right femur, a hepatic metastasized fibrotic tumor from more than 20 centimeters. The patient received surgery, and during surgery a fracture existed in the femur, and after 1 or 2 complications, and he received adjuvant radiotherapy, 12 times 3 gray on the femur, and we used SGRT to position the patient with. From our experience, to use SGRT in extremities or upper legs, this is a a thought process that already needs to start at CT, because you position the patient at CT, and if it's possible, we prefer to do it without bolus, and we try to make sure that the fixation does not cover the treatment area, but is in the meantime also stable. As you can see in this backlog, that the legs are separated, positioned separately, but the backlog does not come up higher than midway through the femur and the upper leg. So we have a VAC leg. It's the right leg that we're treating. We've rotated the left leg externally to get it out of the way and to hopefully reduce the dose in the left leg, and to create a better opening to treat the right leg from different angles. The ROE we've drawn over a small part of the knee, not completely, the complete side of the right upper leg, and as much as we can inside and outside of the right leg, especially the part that's visible above the VAC lock. We use SGRT here as to help us position the leg, to make sure we don't have it rolled or that it's more up or down into the VAC lock. Even though the feet are put to the end of the VAC lock and there's a positioning place for the feet, it still happens that craniocaudal can be off a bit if you only look at the marks on the patient and the VAC lock. In this case, we found the SGRT very useful. So what we like to do is, once we look at all the values, is that we also like to make a treatment capture just to see a little bit more if the leg is rotated either to the left, to the inside or the outside, or if there's a specific part of the leg that we need to position differently. We use 5mm thresholds, but when we leave the room, we want the positioning to be as close to 0 as we can. The magnitude we put into 7mm, and for the rotation, roll and pitch, we use a 3-degree maximum. And this is, again, what we tolerate, but our ideal goal is that everything should be as close to 0. In this case, we did a daily CBCT that had also, that was a request from the doctor due to the intraoperative problems that the patient had, and the doctor wanted to monitor the girth of the leg, to say it like this. Here I have a second example of a knee. We're talking now about a completely different treatment, gone arthrosis. The patient has painful arthrosis in both her knees. She was treated in Q1 in the first quarter of 2020 on both knees, right and left. And after the treatment, the left knee, her pain reduced very good. The right knee, unfortunately, still caused her some pain. So after 5 months, the doctor decided to repeat the treatment for only the right knee. We're talking about a field less than 10 centimeters. The complete knee joint is involved, and it's a 6.5 gray treatment to prevent surgery in the end. We deliver the treatment 3 times a week, Monday, Wednesday, Friday. The patient positioned feet first, supine towards the gantry. We have a feet fix, and we have a cushion under her knee. This cushion under the knee is usually the cause of different setups for the knee, which is why SGRT is a helpful device for us to position the patient. Again, we use tolerances of 5 millimeters and a magnitude of 7, degrees of 3 maximum. But when we leave the room, the values should be as close to 0 as they can. The imaging for this patient was angled KVs. We don't use images directly AP and lateral, because especially with the lateral KV image, both knees are propositioned behind one another, and in the past, unfortunately, we've seen some difficulties with that. To make an image from 45 degrees, it helps separate the knee and make sure that the matching occurs on the right knee. So previous to other cases that we've used sorry, let me start again. I've talked already briefly about the claustrophobic patient that we treated without a mask. This was definitely not a possibility without SGRT. We made different ROIs on the complete chin and neck area, but also both shoulders we used, and we looked at the eyes and here for the larynx to see the swallowing. Of course, the radiation oncologist had to approve all of these tolerances that we set. She also made the tolerance for head and neck CDV to PDV margin bigger than usual, because we didn't have the mask. In the end, we managed to treat this patient 35 times. With a lot of talking with the help of SGRT, but it was, and I think that's why I'd like to show this again, because it's something that our clinic has shown multiple times, both this slide and this case. I think it was a really nice working group of radiation oncologists, medical physicists, and RTTs who came up with this idea to try and treat this patient this way. The other option for her would have been a total laryngectomy, and this was definitely the preferable option. Maybe for the staff, also the harder option, because there was a lot of coaching involved, there was a lot of breaking barriers involved, but altogether we really made this happen. Another example of a different site that we're treating at the moment is a randomized controlled trial comparing closed versus open mask for cranial radiotherapy, also known as the COMFORT study. This study is still ongoing in our clinic, but we're assessing patient comfort and mask stability for open and closed face masks, and we do this with questionnaires for the patient. For the use of the open face mask, we have SGRT to maintain stability and to maintain monitoring the patients. So that would be in the treatment part of the study, where we have what I said before is the main goal of SGRT is to assess head positioning and stability. As you can see, the ROI is drawn over the nose and around the eyes. The eyes itself are blocked out because the blinking can trick the system a bit, but can also give a little bit different values. Of course, there's no use of SGRT with the closed mask, so we use the open face mask combined with the SGRT to the closed face mask and the imaging. There's a specific imaging protocol for this study in which we make once a week pre and post KVs and every day pre KVs before starting the treatment. And during the treatment, we gate. Here I've gathered some traditional and non-traditional sites that we've treated where we've drawn our ROIs. In the left upper corner, you can just see a normal thorax patient that we treated. This was in the beginning. We have come to the conclusion that those ROIs were too big, and now we have switched to different ROIs in the right upper corner. In between you see an upper leg. In the left corner down there is a penile treatment where SGRT was really useful. In the middle picture down, that's the head and neck case that I referred, and on the right side below is a axilla treatment. Well, I'm at the last slide of my presentation. I'd like to thank you all. I just wanted to give you this. We have a challenge where extremities and sarcomas are involved, and that has to do with bolus and coverage and positioning of the treatment area. As you can see, this way of making bolus and putting the patient down can harden SGRT, and it's always a challenge to think about how we can position patients, what helps us, what doesn't help us, but also what do we need and what does the patient need. And I'd like to stop here, and I think this will gives us some challenges to discuss. Thank you very much. Thank you for your attention, and I hope you enjoy this talk and the Congress.